Well, Dad, we are super excited today to be joined by Mark Grant. Mark is a clinical psychologist with over 30 years of experience in the treatment of stress, trauma, and pain. Mark's main interest and experience is in the role of negative emotion resulting from stress as a cause and effect of health problems. Based on recent discoveries from brain scans, Mark regards emotion as both key to many psychological problems, but also as a powerful resource. Associated with this, he is interested in treatments which harness people's emotional resources. We are, as I said, so lucky to be joined by Mark today. Mark, welcome to the podcast. Thanks so much for joining us.
Yes, welcome, Mark.
Thanks, guys. It's great to be here. Looking forward to our conversation today.
Very much so. And now, Mark, just to start, I suppose I'll start by asking you, the area of pain, in some ways, it could be such a challenging area to work in terms of the people, both who experience pain and I imagine also those around the people who experience pain, their family and friends and all that sort of thing. So what led you to work in the area of pain and pain management?
Well, exactly as you say, Rowan, it's the challenging nature of it. And as a psychologist and as a human being, I guess, I was just moved by the plight of people who are in pain, how few resources there were for them, how alone they often felt, just the depth of their suffering. And I really started out not knowing anything. And I just felt incredibly helpless. And so that really began a lifelong journey. I mean, to be honest, just to find out how to help these people and to be able to experience myself as being useful to them in the therapy setting. And of course, I guess it became an incredible learning journey. And I never expected just how much I would learn about myself and how much satisfaction I could ultimately get out of walking with people on those incredible journeys and seeing them come out the other side after a long, really hard battle, and how immensely satisfying that was for me as a therapist. So, and coincidentally, my mother was a chronic pain sufferer. Now that can't have anything to do with it. That must be a coincidence.
Not at all. You won't listen to Freud or anyone else on that one.
No.
Mark, you mentioned about the loneliness that people would feel, and I imagine it is something that many people would feel in terms of it's such an individual thing to go through in some ways, and you'd potentially feel that other people around you didn't understand. But then I suppose someone in your position would potentially see, I suppose, even the amount of people who experience chronic pain and recognise that maybe it is a little bit more prominent than maybe people realise. So what I wonder is just how big of a problem in the community is chronic pain?
Yeah, well, that's right, Rowan. It's one of those strange things where it actually affects quite a substantial number of people. For example, it's estimated that chronic pain will affect 1 in 5 people at some time in their lifetime. So that's a lot of people. And yet it's a bit like, I guess, some other psychological problems like anxiety and things. People are a bit ashamed about it, and not many people understand it. So for the person who's experiencing it, they can feel like they're the only one, when in fact, there's lots of people in the community who are suffering. I also think another reason why perhaps for that is that people don't understand it, because we tend to think of pain really as a reaction to, acute injury. So, you break your leg, six weeks or whatever, you're better, it's healed, fine, you go on with life. So the average person doesn't understand, how people can hurt long after they should be better. And so they just don't know how to really support or understand people who are in chronic pain. And I think also people, family and friends just get a bit tired of it. And doctors, why aren't you better yet? So there's actually a lot of, I think there's a lot of discrimination that goes on as well. A lot of head shaking and eye rolling, especially really unfortunately for women. definitely, I think, get more mistreated than men do if they're suffering from chronic pain. So that's I think that's why, for many reasons, it's a lonely road.
One of the things that came up recently, Mark, and it was wonderful that you gave a workshop to psychologists in our practice just a couple of weeks ago. And one of the things that struck me is many of your messages are hopeful and uplifting about things that people can do. And part of that is addressing some of the misunderstandings, and you were alluding to some there. But one of the things I found fascinating is one of the misunderstandings is about whether chronic pain can have some survival value. Like generally we would have thought, well, chronic pain's kind of like useless. It just gets in the way of people, leads them to feel helpless. But there's actually some evidence that there's some utility in evolution maybe for chronic pain.
Yes, that's a very strange and interesting thing, Chris. I'm glad you answered that question. So it really comes down to our understanding of chronic pain, and we're probably going to move into that shortly, the brain and trauma and things like that. But just going back to the idea of chronic pain, thinking of it in terms of a reaction to physical injury. So from that sort of point of view, pain that persists, pain that's goes beyond the normal healing time, that isn't warning you of danger or injury or that you need to get help, that would really appear to have no evolutionary value. And that's tend to be the way that even chronic pain experts have looked at it, until a few years ago some researchers in the UK decided to test that theory out. Do you want me to retell that story?
Yes, it's very interesting.
The squid. It's an amazing experiment, a very clever experiment. So, these researchers just wanted to test that idea about chronic pain, whether it really, just has no survival value. So what they did was they got a bunch of squid, poor old squid, and they cut off, they basically cut off some tentacles in 2/3 of the squid. So they left 1/3 of the squid fine and dandy, and then and then half of the ones that they cut the tentacles off, they gave them an anesthetic so they wouldn't be in pain, and the other half they left with no anesthetic. So they were basically the chronic pain group, if you like, in the experiment. And then they threw these poor old squid in a tank full of predators, and they found that the squid that had the chronic pain basically survived the best. And so they concluded that somehow chronic pain was, conferring an evolutionary advantage, that it makes people more alert to danger. And this is where the trauma element comes in, that it's been discovered in the last 20 years, or really, it was known 100 years ago, but like a lot of things that kind of got forgotten and then rediscovered. But basically that people who develop chronic pain are more likely to have a background of traumatic stress in their life, maybe physical or sexual abuse, maybe just living in a household where there was domestic violence or instability. And that basically puts their nervous system under a lot of stress. So those kind of individuals are more predisposed to develop chronic pain, and they're more predisposed to have a sort of fight-flight response to threat or anxiety. So what trauma survivors tend to do, and it's pretty smart, is they become Superman or Superwoman. They become really good at pleasing other people, really good at fulfilling their responsibilities, really good at just knowing how to be what the people in their life want them to be, and they can become very successful. And that in a way that keeps them safe, and it keeps them away from feeling vulnerable, and it keeps them away from the shame that often goes from being a survivor of trauma. So they're going along merrily in their life, and they're very successful. They're very in control. They feel powerful and unassailable. And then suddenly they start to get sick, and they have an injury or an accident at work. They develop chronic pain, and they're vulnerable. So guess what happens? Their nervous system goes into a fight-flight response. Everything's switched on. They're all amped up. They can't sleep. They're restless. They're anxious. They're on edge. And they're essentially back in that vulnerable position that they were as a child. And their defense mechanisms have been stripped away from them. So that anxiety, that tension, is their nervous system trying to keep them safe. But unfortunately, it's exacerbating their pain because they're in an elevated kind of level of arousal. Their brain's misinterpreting the signals from their body. Their immune system's not functioning well. And it's sort of like what was initially a good, just tell me to stop talking, guys. What initially was a good way of surviving is now a problem.
Yeah, yes, and what you're getting at there, it seems to reflect a sentence in your book on Change Your Brain, Change Your Pain, where you describe that even though we experience pain physically, chronic pain is a mind-body problem. And you're getting at that somewhat when you talk about trauma reactions and all the rest of it. But if we experience in our body and physically, how is chronic pain a mind-body problem?
Oh, gee, and that's a good question too. So I guess a lot of your listeners I don't think a lot of people know this, but they've gosh, that's such a big question. First of all, it's a mind-body problem because acute pain, physical injury, reaction, quite I suppose cause effect. But when you start to talk about chronic pain, really when a person's had a lot of trauma and then they get injured and they're in pain, there's they start to experience themselves differently. Their immune system functioning changes. Their levels of neurotransmitters in their brain become dysregulated. That's a complex process, but there's basically their levels of dopamine and serotonin and even endorphins and enkephalins decrease, and they become really more susceptible to being in pain. Their brain releases things called cytokines, which are responsible for insomnia, fatigue, and nausea that chronic pain sufferers experience. And emotional areas of the brain become overactive and excited. In fact, of the 9 areas of the brain that they've discovered that are involved in the experience of chronic pain, 7 of those areas are to do with emotional and intellectual functioning, nothing to do with interpreting bodily signals. So although it feels as though it's coming from our body, in actual fact, chronic pain is coming from the brain.
That really struck me from your workshop, that 7 of 9 areas of the brain involved are to do with more emotional functioning. And it just contrasts with something that I was taught about chronic pain early on. This was in the early 80s, and it was like a physio who was a pain expert. And he said that if I look at an X-ray and I see a certain level of damage on that X-ray, then the patient, the person with pain, isn't allowed to have more pain than a certain kind of level unless that's justified by the X-ray. He basically used the term not allowed, like it was almost like a moral judgment. And so that's how strongly people believed that it was just a physical thing, it seems to me. But when you describe the 7 of the 9 areas of the brain involved with emotional functioning, that suggests then that if people have a certain kind of pain experience, it actually likely associates with something real. it will be certain parts of their brain are activated or less activated. And as you say, the different neurotransmitters involved. So there are actual processes going on that you describe in detail in your book, Change Your Brain, Change Your Pain, in your workshops and things like that. There are actual processes going on that actually match the person's experience rather than discredit the person's claims of pain.
Exactly. And anyone who says, like what your physio said, is just ignorant. And unfortunately, that can include treating professionals as well. But it is a hard thing to accept and to understand. But I really want to make the point that because it's in the brain doesn't mean it's not real.
Yes.
I really, really want to make that point very strongly. And I just think it's just a different way of thinking about pain. In actual fact, I've often thought about the term chronic pain, and those two words should never be used together, because as soon as you think pain, you do think, cut, broken leg, injury, and pain, chronic pain. Physical discomfort is only such a small actual dimension of the whole pain experience. So you've got brain changes, you've got insomnia, you've got relationship changes, you've got identity changes, you've got biochemical changes, you've got immune system functioning changes. Pain is just a small component of really what's a very complicated mind-body problem.
Yes, actually, it reminds me what you're saying too. When people are suffering, often they're not mucking around when they report where they're having some challenge or difficulty. And that notion of people not necessarily being believed or being discredited, you mentioned trauma. And we've had some podcast episodes on dissociation, including depersonalization. And what struck me in the early 90s is often when people reported dissociative experiences and certain trauma-related experiences, it could be amnesia or at times depersonalization, like feeling as though they were a different person. Often it was taken that the person was making it up or just being over the top hysterical or whatever. Whereas one of the things I picked up from what you were emphasizing in your work with people with pain, you take it very seriously when people describe the distress that they have. And you're looking to understand that also, the impact on them and from their point of view. So it seems to me an important part of pain, well, helping people is to validate their experience, but it seems that part of that is helping the person accept their pain, have ways of maybe accepting it rather than trying to avoid it or pretend it's not there. Or
spot on, Chris. And that word validation is the key thing here. So if you invalidate a person, whatever it is they're experiencing, if you validate their feelings, you're invalidating them. And that's really what children who are abused or who are neglected have experienced. They've experienced invalidation, and they've now got chronic pain for whatever reason, and they're being invalidated again. So it's actually a repeat of the trauma that they initially suffered and have tried to overcome. It's really very traumatizing, and it's something that really bugs me, I have to admit. That these poor people are just being, sent to the cleaners again because people don't understand what they're going through. And I think that's actually, Rowan, what really, I think, now that I think about it, has really hooked me in this work. It's just being the one to say, I believe in the reality of your experience, and seeing the relief on people's faces when you do that. That's I'm sure, Chris, you know that one.
Yeah, with people with trauma reactions, very similar. Yes.
Yeah, absolutely. And I find that fascinating in some ways, Mark, in terms of that idea of really accepting pain, almost, I suppose, really kind of almost drilling down and not avoiding the pain. And I suppose, or not avoiding the fact that we're experiencing chronic pain, for example. And what I wonder there is, for example, one tactic almost, or one strategy that I hear about managing with pain is to try and whether we distract ourselves in a way where we're not focusing on the pain all the time. But I wonder if you could speak a little bit to maybe the difference between, for example, avoiding pain and avoiding the fact that we experience pain and distracting ourselves from that.
Yeah, great question, Rowan. So how can I put this? I guess people who are trauma survivors have spent a lot of their life avoiding their feelings as a way of surviving and coping and being strong. And when they have a crisis such as chronic pain and disability, they just want to keep on doing that. And that really means not paying attention to their body, not paying attention to their feelings, not paying attention to their needs, just trying to be what the world wants them to be, and get back onto that way of living. And they struggle. They most of them, my clients, really struggle to do that, and they can't because they're just in too much pain. Their body won't let them. And in a kind of crazy way, chronic pain forces them to have to stop and have a look at themselves, deal with their trauma, learn to be with themselves, to pay attention to their feelings, to get their needs met, to become a whole person again. So in a big way, the way out of pain really is to reconnect with oneself and to be present to one's own needs and experience. So in a way, they have to become less avoidant. However, having said that, there's also a place for avoidance. If a person's in a lot of pain and having flare-ups, the psychological healing journey can take months, years, and you can't be, you don't want to be paying attention to your pain too much, because then it becomes overwhelming. So it's really about finding a balance between avoidance and being present. And D.H. Lawrence, who was a chronic pain sufferer, as it happens, he said something like, to be my whole self when I'm suffering is just too awful. I have to sort of escape myself sometimes, to not be myself. And that's a valid way of coping, but it's finding the right balance between avoidance and being present.
Yes, and much of your approach, as we've talked about, is validating of the person. It's hopeful, but also some of the things you're describing at the moment, Mark, it shows that it's also complex and challenging, and it sometimes means that you're encouraging people to acknowledge or process things that might be difficult to deal with. One of the things that you've highlighted is how people can have complications to do with past attachment problems. And so how they've maybe connected with their parents and others. So could you say a little bit more about the experience of attachment and how that affects people's reactions to pain?
Certainly. So of course, attachment, I guess your listeners know, but just for the record, it's the bond between a parent and a child, or anyone we love and who's close to us. And we know that attachment is really important for self-soothing, for comforting, that it produces oxytocin and feel-good sort of chemicals in the human body. And so attachment is really the basic human self-regulating process, and it's the natural thing to do. Now, let's say you grew up in an abusive family or a dysfunctional family, and you couldn't get, the attachment that you need isn't normally available to you. Well, then you've got a problem. How do you self-regulate? How do you self-soothe? Well, you become a workaholic. You start abusing drugs. You engage in risky behaviors. You basically find alternatives to depending on people, to relying on people in order to find comfort and relief. But none of those methods, as you can tell, are very healthy. And in the long run, they lead to chronic pain. So that's the attachment piece. And just for your listeners' interest, in case that you don't know, these statistics regarding attachment problems are alarming. The research shows that up to 50% of us will have some sort of attachment problem, and that doesn't, that includes all us mental health professionals too. And the attachment problems are common as dirt. In chronic pain sufferers, they're 75%. So they're that's a big causal factor, and it's again because of the stress and wear and tear that they put on their bodies. So really, chronic, if you got hurt at work, it's work. I'm treating a nurse at the moment who developed back pain after a patient, she was carrying fell on her, but her really, she didn't have good attachment. She had some trauma in her childhood, and then as she became older, she took on a lot of responsibilities as a mother, as a wife, as a worker, and her chronic pain really started when she was 7. If you look at it that way. So again, understanding the trauma angle gives you really an insight into understanding the genesis of chronic pain, which just will never make sense if you try to understand it in terms of the present injury.
Yes, and so it comes across very much from what you've described that for anyone to understand their chronic pain, or certainly those health professionals looking to help them, it's important to do some kind of routine, at least screening or assessment of past trauma and attachment to help understand the person more, not to have other explanations for their problems or why they have complaints, so to speak, which can sometimes be dismissively. The word complaint can be treated dismissively when really it's the person looking to acknowledge their suffering as they're experiencing it. But the way that you describe that, to take some note and care and interest about those influences seems important. But another thing, it seems to me that sometimes people who are dealing with chronic pain might find challenging is the idea of not continuing to look for some kind of, well, I might say, external physical fix. It's sometimes described as a medical merry-go-round. The person goes from one surgery to the next, or they're looking for one kind of medication to the next. And so people can get caught up in that, whereas you're encouraging people to look more holistically at their experience as well, and looking at the mind-body side of things. So how do you look to deal with that if someone's quite focused on looking at that medical fix, but that's been going on maybe for years and not progressing very far?
Well, thanks, Chris. Good question. There's lots of reasons for that. For example, again, just the way people understand pain, and then of course they've got the trauma angle. So, and the avoidance. So if you don't want to deal with your childhood stuff, it's really a lot easier to think of it as a medical problem and look to the doctors for a solution, rather than having to look really to oneself to understand and to deal with the problem. And I would say that just about every chronic pain sufferer has that journey to make, and they will initially look to, of course, just naturally look to the medical profession and perhaps other treatment modalities for a solution to their problems. And then, of course, when that doesn't work, they sort of become a bit of a, anxious and depressed, and a bit of a crisis sets in. And hopefully sooner or later at that time, they'll seek out or be sent to talk to a psychologist. And human beings are, we're interesting creatures. We'll when denial doesn't work, we eventually go, there's some, I think people come to a point of acceptance. They go, there's something going on here. This is not it. And so I find that when a person's ready, they're and sometimes it's my job to help them to get to that point. When they've exhausted all the medical kind of options, there's only really one person left in the room for them to look at. And I guess I'm just saying, I don't sort of say, right, it's all to do with your childhood, but I think people start to become open to considering that in their own time. it's some quicker, some longer, but sooner or later they start to question, the way they think about things, the way they understand it, and that's when they're really ready to start taking responsibility for their health, their well-being, for dealing with, whatever traumatic patterns might be maintaining their pain.
Well, I think it is one of the things, Mark, that I suppose separates you, as you say, from other health professionals in that way. And it was alarming, some of the statistics that you were saying before, in terms of 50% of people suffering from some, whether it be area or some, I suppose, issue with their attachment. It is sort of a really dim way of saying it, sort of thing. But I suppose also when you look at those sorts of figures, I suppose it puts, for example, maybe the opioid crisis into a little bit more perspective, and particularly maybe in America, you see how many people are really going to medications for things like chronic pain. But what I wonder is what is the role of medication in managing chronic pain? Because it's potentially not to say that, just because there's potentially some underlying sort of causational elements as well, that there is no role for medication. So I wonder, I suppose, is there a role for medication, and what is that role?
No, definitely. So first of all, medication is vital for managing acute pain, and it's vital for managing post-operative pain. And the research shows that if it's not done right in the beginning, that will predispose a person to the development of chronic pain. So with pain, you've got to hit it and hit it hard and early. That's really where medication comes in helpful. Now, when as time goes by and the pain isn't getting better, really medication becomes less useful and actually can create a lot more problems than it's solving. And we're not just talking about painkillers here. We're talking about sleeping pills, mood stabilizers, antidepressants. So the typical chronic pain sufferer is on about 5 medications. And unfortunately, what happens is something that started out as being helpful actually ends up robbing them of their autonomy and their independence. And, they feel, kind of brain dead and dozy, and, it's just a problem. They really, chronic pain sufferers don't want to be on medication. No one's enjoying it, but they don't see any other alternative. So, and again, that when they get to that point where they're ready to sort of start, I suppose, looking at themselves and dealing with the emotions, they're really ready to start learning ways of coping that don't depend on medication. So I see it as there's a kind of like a normal curve, and people go through. They sort of start off on probably modest medication, end up on, some of my clients, they come into my office on enough opioids to knock out an elephant, but because they've got tolerance, it's not affecting them. But they're pretty zonked, and usually there's a point at which they go, I've had enough of this, and so and then when they start to have therapy and things like that, their medication usage drops, sometimes slowly, sometimes quite dramatically, and they start to stand on their own 2 feet and don't need it anymore. So it's a journey, and no one wants to stay on medication. It's a journey. It's the best way to describe it.
Well, that's a good lead in now to the different kind of techniques, the practical techniques that can help people. And I'd have to say, Mark, your lead transformed our ways of working with pain in this practice with the use of a particular technique called bilateral stimulation that relates to a therapy approach called EMDR, eye movement desensitization and reprocessing, which we have not talked about much on this podcast. But bilateral stimulation is such an interesting, accessible, easy to use technique. And if we can just lead you in that way to talk about bilateral stimulation as a strategy and a technique for dealing with chronic pain.
Certainly. I'd be delighted to. That's sort of my life's work, really, Chris, as you know.
Absolutely. You've done much of that work in many countries. You've trained innumerable clinicians, but that is the number one go-to technique we use of any particular intervention in our practice.
Mark, I will just say, Dad said about the practice, it's also the family as well, in terms of, there was plenty of times when I was young when it was sort of, I've maybe, complaining about something a little bit too much, and, here we go, Rowan, get on the earphones. So we all have to thank you, Mark.
You one technique you could use with your family without crossing a line. So yes.
Well, thanks for sharing that, Rowan, and I'll take that and I'll pass it on to Francine Shapiro, who really is due all the thanks. Of course, she's the discoverer of EMDR, sadly no longer with us, but she discovered it quite bilateral stimulation quite by happenstance, as she was dealing with some issues in her life while she was walking the park one day and experienced some spontaneous saccadic eye movements, and then she noticed after the eye movements that she felt less upset about. She actually had a cancer diagnosis, and one thing led to another, and she started trying it with Vietnam veterans, and it really helped them with their trauma. And she developed this treatment method called EMDR, which stands for eye movement desensitization and reprocessing. And she mainly relies on eye movements. And basically, I suppose the core element is that you get the person to focus on their traumatic memory or their pain, and simultaneously attend to bilateral eye movements or audio tones, and something magical happens, and people start to feel more relaxed. They stop feeling anxious. They stop ruminating, and they feel more calm and more embodied, more in the present, and less of that monkey on the back kind of feeling. And then that effect seems to be relatively enduring. So 5, 10, 15, 20 minutes later, an hour, the next day, that those memories, those responses are permanently altered.
Yeah, yes. And so one thing with the eye movements, we use that as a main trauma therapy technique, Mark, and it largely involves the person moving their eyes from left to right for a set of eye movements, doesn't it, over half a minute or a minute or so. And the therapist might be sitting close to the person, waving their fingers back and forth in front of their eyes to help the person focus on that and move their eyes to the right and left. But you often use the auditory stimulation, and you have apps that are very accessible that we'll talk about later on, where what the person puts in earplugs or puts on earphones, and it's basically one sound like a click or something in the right and then the left, but they're different kind of sounds you can use. But essentially, it's rapidly alternating between the right and left ear, for example.
Correct. So bilateral stimulation is it's a core treatment element of the EMDR, and a somewhat controversial treatment element, really. And a lot of people were poo-pooing it and saying, "Oh, it's just distraction." And there was, when EMDR was kind of arrived on the scene, there was no research regarding the treatment mechanisms. And I guess other professionals at the time just thought it was a kind of modification of exposure therapy or something like that. And it's taken really up until fairly recently for research to emerge. Now, a study in Nature in 2017, one by Bayek et al., where they did an experiment with mice and proved that bilateral stimulation extinguishes their fear response in a way that normal exposure therapy doesn't. And they actually were able to trace the brain circuits that do that. There is evidence now to prove that bilateral stimulation is doing something. I think for the layperson, probably the best way to explain it is to imagine that you're hijacking your own fight-flight response, and I'll explain what I mean by that. So if you're anxious about something, let's say you're anxious about being in chronic pain, which is quite common experience. It's, being in pain is quite scary and stressful. So your nervous system is essentially in a state of arousal, of fight, flight, of fear. And then if you're subjected to bilateral stimulation, so I'm just going to click my fingers now. Can you hear that? Yeah. So basically, when your brain detects bilateral stimulation, auditory tones like that, the emotional part of the brain goes into operation, and it's part of an area of the brain that is responsible for what's called the orienting response. And the orienting response is the part of your brain that really detects novel stimuli in your environment. And it's part of your survival response. So when you're living in the savannah 40,000 years ago and you heard a rustle in the grass while you're having your lunch, you wanted to make sure that wasn't a saber-toothed tiger sneaking up behind you. So there we've got this inbuilt response to danger. So you're feeling anxious about being in chronic pain. Then you notice bilateral stimulation. You're actually reactivating your fight-flight response, but you're reactivating it to a benign stimuli. So what happens is you're hijacking your fight-flight response. It's pretty smart. And after 30 seconds of bilateral stimulation, your brain goes, well, whatever that is, it isn't a saber-toothed tiger, and you start to relax. And it happens quite quickly and quite automatically. And Rowan, you can probably vouch for that. And it almost happens without you doing anything. It's kind of quite magical when you experience it. It just seems too easy. But it's only because we don't really think of our brain in those ways. So that's how I kind of explain it. And I just think it's just really there's something that should be taught in school, that you can hijack your own fight-flight response.
Well, it is. Yeah, it's fascinating to hear you describe that, because as you say, I certainly can vouch for that. And as I say, yeah, have used the app. And I suppose before speaking to you and before hearing you describe that, one of the things that stood out to me about the app is, I suppose, the range of things that it is applicable for, in terms of, I've used it from, basically, food poisoning, without giving too much detail away, right through to, having quite, anxious thoughts, maybe ruminating on something, and yeah, had conversations and just almost got the app out straight away. But it is interesting to hear almost the science behind it and the mechanics of it, because yeah, what struck me was just the range of application that it did have. And I will just mention as well, we will put up the link to your great app as well, Anxiety Release, on our podcast page for today at psychspills.com.au as well.
Thank you.
Actually, I might mention with that too, Mark, we have a demonstration video that we use in our practice that many people have accessed, and it also describes how you can use the app for worry, or sometimes if people have been studying into the evening and their mind's overactive, it can seem to settle one's mind. Yeah. And so we'll have those resources there, including ways of accessing your overcomingpain.com website, which has lots of
thanks guys. I really appreciate that. I also wanted to just talking about the bilateral stimulation. So it creates this relaxation response, and of course that changes the way. Not only makes you feel relaxed. I mean, that's nice, but it also changes the way you see things. Because when we're relaxed, we feel, we think better. We're more creative. We feel more confident. We feel more able to cope with things. So quite a few people so that's one element of, that's one byproduct of bilateral stimulation that's really very useful and helpful. And I have people who at the end of the treatment, their pain's not a lot different, but they say, I'm not that worried about it. It's just not center stage. It's not such a big deal. I'm just getting on with my life. And it's amazing, from this person who came in who was a scared rabbit, of their pain, just because they're able to tame the fear. That's a huge thing.
You described that very well, taming the fear and the acceptance with it, but it's also quite striking how people can have sensory changes. Like they might imagine the pain as a big red hot ball in their elbow, for example, but after a while it can seem smaller or fainter. Now, one of the things I find interesting, and we observe this with our clients using the app, but also you've described many different ways that people experience the sensory experience of pain's different. There's something else in its place. And you highlight this idea, there's something else in the place of what was there before, which has a kind of calming impact or helpful impact.
Oh, that's a great question. That's a great observation and good question, Chris. So one of the problems with chronic pain is that the brain really loses the capacity to experience joy and pleasure. And it's interpreting everything pretty well as painful. So when a person, when a person's experienced bilateral stimulation and they're feeling more relaxed, it's the treatment doesn't stop there. Then really, I try to help them connect with those feelings of relaxation, to notice them in their body, to notice the qualities of those sensations, and to link them to other experiences they've had of pleasure and comfort. So really, we're starting a process of retraining the brain to notice different bodily signals and to start developing memories of comfort and relief, and really starting that whole neuroplastic process of changing the way people interpret their bodily signals, changing the way they relate to their pain, and changing their pain. Change your brain, change your pain.
Yes, and this can come up, say, in the trauma area, and that's the main technique, EMDR, that we use with our clients with post-traumatic stress. And it can be remarkable that someone goes from remembering a situation where they felt helpless and like a victim who they think's handled it poorly, but then they look back and they think how effectively they actually managed against the odds at the time and how well they did survive. Their thoughts and their perceptions about the trauma, they come to remember and experience it differently, and their distress comes down. Now, you've talked a lot and you do a lot of training when there's a combination of post-traumatic stress or trauma and pain. For example, someone might have had an accident. Actually, they might even be suffering from phantom limb pain. That's amazing how EMDR can help with phantom limb pain as one example of trauma. Would you describe a bit more about that, how EMDR can help when there's trauma plus pain?
Yeah, sure. So trauma is a big term, but if a person's, let's just take a simple, we'll take an example. We can talk about phantom limb pain. So when a person's lost a limb due to a motor vehicle accident or an infection, they can develop, phantom limb pain, where really that's the classic example of brain pain, because there is no limb to feel pain, and yet they're experiencing pain in that limb that is no longer there. So where is that coming from? And that pain is really what we think of now as a memory. It's called a procedural memory. So it's not like a memory of what did you have for lunch today. It's a memory of something that your body has experienced that it can't forget. And in the sense that EMDR is about changing memories, about processing traumatic memories, it's probably most suited for those kinds of pain that are really part of a traumatic memory. So there's a great example of this with a guy in Germany who was in a motor. This has been written up. I can't remember the authors right now, but he was in a motorcycle accident, and he had his leg was ripped off right up to the thighs, and he was in a lot of pain. A lot of other things happened around that. He had some medical trauma associated with that, and after a couple of years of normal treatment, he just wasn't getting better. He was on tons of medication. And he found out somehow he got into EMDR, and within 9 sessions of EMDR, his phantom limb pain was completely resolved, and he's now working as a diver, a Navy training instructor for diving. And
terrific.
The EMDR, they targeted the accident that caused his pain. They targeted the pain itself. They targeted some of the medical trauma that he'd experienced in his treatment, and some other things that had happened in his life. And because he was really he had actually a good family background. He didn't have attachment problems. He didn't have any other trauma. And those are the best clients for that kind of work. It's you can do a lot in a few sessions, whereas I guess clients who've had more complex, stressful backgrounds, it tends to be a bit longer term. But that's a true story, and that's just amazing. Just shows you what's possible.
Well, it's wonderful that there can be treatments that can be so targeted for such complex difficulties. But one of the things that comes across in your training as well is there are a whole range of different pain management techniques that you've described. And one that I used for the first time yesterday, it'd be wonderful if you can explain this, is pendulation. That can be something so helpful. Could you describe pendulation for us?
I can, Chris, and I just want to preface that by saying that of course I don't just do EMDR. I work holistically. I use a variety of strategies, and really for people who have complex medical histories and trauma backgrounds, I would almost never just use EMDR alone. I'm always supplementing it with adjunctive strategies such as pendulation, hypnosis, mindfulness, and so on. So, and those strategies are designed to help people with persistent ongoing pain. So pendulation is a process that was really developed by Peter Levine, who wrote a book called Waking the Tiger. And he's a man who knows a lot about, I suppose, how trauma is stored in the body. And really the idea is that with pendulation, it is that when we're in pain, our attention tends to be on that area of our body, and that's kind of all we notice, and that tends to have a self-reinforcing effect. But of course, no one's in pain everywhere. There are parts of our body that are not in pain, maybe our little finger, maybe our big toe. So pendulation involves, really getting the client to direct their attention to a part of their body that feels pain-free, that feels comfortable, that feels normal. And it'll be different for everybody, but it involves really getting them to pay attention to that area for a few minutes with guided instructions. So just noticing what it feels like there, just noting the feelings of calm, comfort, the muscles are soft, the blood is flowing like it should be, just noticing the feeling of well-being there, everything's as it should be. And maybe if there's a color that goes with that, a nice healing color, whatever comes to mind. And then after a few minutes of that, you've got the person, they're really not thinking about their pain. They're having a nice experience of focusing on feelings of comfort and well-being. And then you say, oh, by the way, what's happening with your, they're in pain right now. And they go, well, gee, now that you mention it, it doesn't really seems different to how it felt when we first started talking. And you go, great. And then you pendulate back again to the area of comfort and spend another 2 or 3 minutes just focusing on that, on the color and the feelings and the sensations and so on. And then you ask them, oh, by the way, how's that? What are you noticing with the pain now? And they go, oh, gee, it seems even less, painful and distressing now. And you do that 3 or 4 times. And really all it is redirecting attention. But it's very hard for a person to do that on their own. And that's where having a therapist comes in handy.
Yes, but perhaps after having that experience, people can practice that a little bit at home, do you find? Once people have been exposed to it.
I've got a recording of that on my Overcoming Pain app, so that people can have that guided experience of that. Because it's very hard to not notice pain unless you've got someone guide, your attention.
Yes.
So attention is the brain, and attention is the number 2 function of the human brain. The brain only does 2 things, really. It pays attention and it decides whether to keep it or forget it. So attention and memory are the 2 main functions of the brain. And so when you can manipulate, when a person can learn to change their focus of attention, you're well on the way to being able to control your pain.
Okay, and one of the things that reminds me of too, a quite specific way of changing people's attention is you've described different types of antidote imagery. Can you tell us about antidote imagery?
Oh yeah, sure. So how can I put this? I guess antidote imagery is really utilizing another brain capacity, and that is imagination. So antidote imagery involves creating a pain antidote, an imagined pain antidote based on the client's description of their pain. So I would ask the client, describe your pain. What does it feel like in terms of its size, its shape, its color? And let's say, like you said, they get a big red ball. And then I'd say, now I want you just to park that for a minute and think of something that could take that away or make it feel better. The opposite of that, something cool, something that's sort of kind of smaller or shrinking or diminishing. And they might come up with, see a metal actually shrinking, or they might come up with an anesthetic mist, or really it's quite infinite. And then and then you just get them to imagine that antidote imagery, really alleviating their pain, changing the way they feel. So it's kind of like a mental opiate. It's just like a mind opiate, but it has to be kind of based on the description of the pain. And it's called, in psychology we call that mentalizing. When you're actually creating a mental representation of what's happening. And most people in pain don't do that. They just feel hurt. They feel the ache. They feel, the emotion, but they're not really mental. They're not really. You can't do much with that. But if you can mentalize it, you can do anything with it, because imagination is infinite.
And with that hurt and say the tension that can go with that, some common psychological strategies include relaxation techniques or mindfulness techniques. Well, what would be the role, for example, with relaxation techniques and pain?
Well, relaxation techniques, of course, help to really reduce the levels of tension in the body. And they've got a long history in the treatment of chronic pain. The difference, and they're essential, but the difference between relaxation and EMDR is that relaxation hasn't been actually found to do much in terms of people's experience of their pain. And in a way, maybe Rowan, you can validate this too. Relaxation is hard work. You've got to concentrate. You've got to take time out. Whereas bilateral stimulation is instant, it's quick, it's accessible. You don't have to imagine anything. It's kind of relaxation for idiots. It's just so easy and quick and natural. So I have all, relaxation has its place, but and all my clients I teach to do it. But again, I come back to the bilateral stimulation for its ease and its convenience.
Yeah, and I will say, yes, certainly, can validate that as well. And I suppose like for me as well, someone like I'm not naturally someone who feels that, as you say, like I'm no good at quieting my mind down in certain situations. And that's where it is that, really easy alternative that way. But I suppose, Mark, we better let you go in a moment. It's been absolutely brilliant to talk to you, and I feel that I've learned so much. And I suppose just as a final question from me, and that's to do with the role of social support in pain management, because I suppose, even at the start of this conversation, I almost viewed pain as in many ways an inherently individual thing. It's something that, we go through by ourselves. And in many ways, it's potentially very hard to get across to those around us. But speaking about things like attachment and about our connection to those around us, it seems to allude to me that there is maybe a real need or a real part of social connection, which is connected to pain in some ways, in terms of, it seems to me maybe if we can develop more of that social connection, it will help our experience of pain. Is that the case at all?
Rowan, there's an old saying, you've got to love yourself before you can be loved by anybody else. And of course, really in therapy with chronic pain sufferers, it's as much as about helping people learn to love themselves and to look after themselves. And once they do that, their relationships change. They learned, for example, the harried housewife learns that she doesn't have to do everything. She can ask her spouse for support. And if he says no, she's going to tell him, buddy, you better get your act together, or you're going to be on the first train out of town. And so I guess, when people, that support, you can't get support unless you know how to support yourself. It's an extension. And really what happens in a lot of my treatment is that people learn to ask for what they want, to get the support they need. And it's a kind of chicken and egg situation. It's just no good just saying, look, you need to go and talk with someone. If you're telling that to someone who says, it's not safe to trust anybody, I can't show my vulnerability, that's not going to work. They've got to do that emotional work first, and then they can access the support and really know how to give that to themselves. So, yeah.
Great. And before Rowan reviews some of the resources with you and anything else you'd like to direct people's attention to, Mark, for follow-up materials. Look, the main thing I want to say, Mark, is it's a delight to be exposed to your clarity of explanations. You explain things very clearly, but over and above that, one thing I admire so much about your approach is it's so utterly compassionate, humanistic. You're really interested in people and really interested in people's well-being. And I think that really helps that holistic kind of approach you're describing, and the way that you invite people to be self-compassionate themselves as well. You're leading people on a journey to understand themselves more fully that has challenges to it, but also rewards along the way. And so it's the way you describe it, it really sounds like a hero's journey dealing with pain that we've talked about before. But thank you so much for the way that you model that compassion, that holistic approach, and that interest that you show people. And that would seem to be an important part of the healing elements of your work, I imagine.
Oh, look, thank you so much, Chris. I really am. I come from a place of love, and and that's a big word. That's a big word, and I say it with humility and respect. That's not something I say casually or trivially, and it's a big commitment. When I take a client on, they're not just a client or a patient or a customer. They're a human being who I'm going to have a relationship with, who I'm going to walk the hero's journey with, and we're going to go to some dark places together. So there has to be trust. There has to be an alliance, and but what a great journey to take! What a privilege and what a joy.
Well, yeah, that all absolutely comes across, Mark. And also add to that, just the empowerment that it must give people as well, in terms of, I imagine part of suffering chronic pain would be, for example, something as practical as not being able to anticipate, activities on the weekend. And, it could be, a round of golf or 9 holes of golf in a cart. That could be something that could be seen to be, incredibly tough. But then when you go through some of this sort of stuff, then I imagine people would feel confident and empowered to, I guess, start to become themselves again, to start to go back to some of these hobbies that they've maybe avoided as well.
They do. Often after a very long, hard road, after a long setbacks, some of my clients, really they just wanted to take some pills and end it all. So when you get to that point, and when they've been to the darkest places, and they're saying, you know, I've got a life now, and life's worth living. I can see a future and hope. It's just so rewarding. I couldn't imagine a better, more satisfying job. And when a client says at the end of that, and many clients say this, and it blows me away. They say, "This is the best thing that ever happened to me." So, you know, someone who's lost a leg, or someone who can't play sport anymore, or you know, because they've grown so much as a person. It's truly humbling.
Well, we will just mention a couple of things. For those watching the video, we've got your book here, Mark, Change Your Brain, Change Your Pain, which, it's a brilliant book. A couple of apps as well that we've mentioned too. We've got the anxiety release one, which, you know, that's something that I always mention that to friends at uni to sort of try and get a few sort of cheap points amongst people. So it's something that I can certainly vouch for myself. We've got Overcoming Pain, the app, and the Sleep Restore app. And the website as well, www.overcomingpain.com. We'll put all the links to those up on the episode page for today. But Mark, thank you so much for chatting to both myself and Dad. It's been wonderful to chat to you, and I feel that I've really learned so much. And as I say, you know, we'll I imagine have a few psychologists on the program, but you'll be one who I've personally enjoyed your stuff as much as anyone, because particularly with that app, it's come in very handy in times of distress over the time.
Thank you very much. My pleasure.
And thank you so much, Mark. And we know that your positive influence is spreading far and wide. I know that you're doing some training with the British Department of Defence as one example, but you've done much work at an international level, as well as trained many people in Australia. And just very recently, myself and my colleagues benefited greatly from that. So terrific to speak with you, Mark. Thanks very much for being with us today.